Today is January 18th, 2022. We're kicking off our monthly Virtual Lyme Impact Series with a speaker of a bit of renown. This will be a slightly different format this evening, one that actually will prove to be a little bit better. Before I touch on that, I do want to introduce, we have with us tonight Amy Teal. Amy is the director of our 𝗟𝗵𝗃𝗀𝗃 prevention program. We have with us as well William Moore. Bill is on the board of Pennsylvania Lyme. I myself am president, but I also am a regional leader of the Harrisburg Area Support Group. The three of us that represent PA Lyme are all regional leaders. So a lot of you that are participating this evening, you're affiliated or a member of, or you're either on our email distribution or Facebook. PA Lyme has 18 support group regions in Pennsylvania. All of them are really run by somebody that either has Lyme or their child has Lyme. I would say that Pennsylvania, not only are we the state that has the highest incidence year after year, 7 years in a row, of Lyme disease, new case infections, CDC, we also are a state that is just really highly organized. I think the important thing about PA Lyme is it's 100% volunteer organization. I think through the good graces of volunteers, dedication, compassion, and also a support system, a network, those of you that are watching, certainly your stakeholders in the success of PA Lyme. So for this evening, some of the housekeeping is going to be, I am going to really cut a lot of the announcements short. We want to give Dr. Horowitz a lot of time to go into his presentation. I'm going to do a very quick screen share that gives you a sense of the overview as I then go into his bio. His presentation will probably go a little bit longer, and he has agreed to stay longer than 8:30 for Q&A. My experience of seeing Dr. Horowitz speak, whether it's at ILADS or some other national function, is just a lot of Q&A. People will line up and stand in a row to ask questions. Recognizing that we didn't want to cut the presentation that Dr. Horowitz has tonight short, and we wanted to make sure that we allow for enough time for Q&A. So the way this will work is, if you have a question and you're on Zoom, ask the question down at the bottom, click Q&A, and ask your question there. Amy Teal will facilitate all of the questions coming in. We ask that you do it in the questions and answer queue and not the chat queue. For those of you that are on Facebook, on the Pennsylvania Lyme Facebook site, you can ask your questions there. Amy's going to be collecting all of the questions, organizing, prioritizing them, and at the end of Dr. Horowitz's discussion, she will then put the questions forth to Dr. Horowitz to answer. So with that format, again, if you want to drop off, need to drop off sharp at 8:30, feel free. For those of you that want to stay, we encourage you to stay as well. So I'm going to go to a share screen and allow me to get into my notes here. And as I said, Dr. Horowitz, and so the subject matter, which is really very timely, future Lyme tick-borne diseases prevention, diagnosis, and some of the treatment options. For those of you that are abundantly familiar with Dr. Horowitz, you recognize the body of work that he has put forth into the Lyme community. What I would like to do is give you really a sense, an overview of his background and his bio. He is a board-certified internist, medical director of the Hudson Valley Healing Arts Center, which is an integrative medical center which combines classical and complementary approaches to the treatment of Lyme and tick-borne diseases. He has treated over 13,000 tick-borne patients in the last 30 years. probably more than any other doctor that I'm aware of. He's a founding member and past president of the International Lyme and Associated Diseases Society, ILADS, which is near and dear to our heart. He has trained over 200 healthcare providers in the diagnosis and caring of patients with treatment-resistant tick-borne disorders. And that's operative, that are treatment-resistant. For those of us that have gone 5, 10, a decade of treatment to try to break through the resistance to try to get better. He is also the past recipient of the Humanitarian of the Year Award by the Turn the Corner Foundation. He has co-authored peer-reviewed Lyme guidelines published plenty of times in medical literature, really on the novel persister drugs for the treatment of Lyme disease and co-infections, as well as the role of the 16-point MISTIS model for chronic illness. He has really expanded his sphere of influence, and not only working individually with patients, starting to outsource his knowledge to start working with institutions. Some of those institutions are government agencies: China, Australia, Belgium, France, United Kingdom. He is a member of the Health and Human Services Tick-Borne Disease Working Group. He's the co-chair of the other tick-borne disease co-infection subcommittee from 2017 to 2019, reporting recommendations federally to Congress to improve the care for individuals suffering with tick-borne diseases. He was elected to serve in New York for the Department of Health Tick-Borne Disease Working Group. So some of you may be familiar with some of the body of work of books that he has written. I think probably 6, 8 years ago, Why Can't I Get Better really put him on the map for myself. And then he followed up with that back in 2017 with How Can I Get Better? So the how do I get diagnosed? How can I get better? And then how do I get better? So in addition to the books that he has written, he has a new book that is coming out really next month, in the next couple of months. It's a 𝗘𝗏, which I think is a pretty fascinating vernacular for a science fiction climate change novel. It provides some of the solutions to the present climate crisis. If you're following tick-borne diseases and you look at the CDC map, you know in the last 20 years, the epicenter is in Lyme, Connecticut. And that epicenter, like a nuclear bomb, is expanding in concentric circles, and it's going south, and climate change is really helping to promote the species of ticks that are carrying tick-borne illnesses. So the book that he wrote focuses on climate change. It's got a science fiction background. That platform also is layered with a lot of humor. And in talking to Dr. Horowitz, he was wanting me to share, this is a book that Lyme patients are going to get. They're going to understand some of the nuances that maybe other readers don't understand. We're going to get it because of our Lyme exposure and because of our Lyme background. So with that, I'm going to go ahead and do a stop share. Dr. Horowitz, I want to thank you tremendously. Allow me to turn it over to you.
Thank you. So, Eric, thank you for inviting me. I'm really happy to be able to do this for you all and to launch your series for this year. So I will actually try and do my best to keep it down to 45 minutes. I don't think I'm going to need to go longer. And before I even give the talk, let me just give you a brief overview of what I'm going to talk about, because I've generally found that the best way of doing any sharing of information and teaching is to first tell you what I'm going to tell you, then show it to you and just repeat it a couple of times. So the first and most important thing I'm going to share with you tonight is you should have hope. There are a lot of advances that have been made in the last decade in Lyme. I'll be sharing with you tonight the publications that Dr. Phyllis Freeman and I have done on Dapsone combination therapy. My wife at this point is now 3.5 years in full remission. She was sick for probably 30 years. Every piece of the MSIDS map that I'm going to show you today, we're going to go through the MSIDS map briefly so that, for example, if someone out there says, hey, I'm dizzy, what's the dizziness from? I can show you, oh, well, if you haven't been checked for POTS, if your dizziness is standing up, then you may find that, and your heart rate goes fast, that's a sign of POTS, because post-infectious POTS is now being seen quite frequently with Lyme and also now with COVID in our long haulers. So and I will be discussing COVID-19 and the overlaps with Lyme. One of the things that was very important when we published our 2 articles on COVID is that the same inflammatory cytokines that I've been dealing with in Lyme patients for the last 35 years, same ones are being seen in COVID. So the reason I knew to use glutathione and a lot of the antioxidants I'm going to talk to you about tonight, which are for COVID and for Lyme, it all comes basically from my background being a Lyme doc, where Babesia patients would come into my office going, I'm really short of breath. And I would give them a 2,000 gram shot of glutathione. And within minutes, they go, wow, my breathing is so much better. So when our first COVID patients came in, yes, sir.
Excuse me for interrupting. There is on your glasses a purple reflection. When perfect. You are ready for prime time.
Those are my blue light glasses, by the way, so I don't destroy my retina as I get older, but I don't need them for this. It's fine. So what I'm going to show you this evening is the same inflammatory molecules that you see in COVID-19 and Lyme. I'm going to show you 3 switches. As if you walked into your house and you had 3 light switches you want to put on or off. I just want to show you the 3 major switches that are in COVID, but we also see in Lyme. The first one is called Nrf2 Inside the nucleus turns on a lot of the inflammatory molecules you see with Lyme and COVID. It's blocked by N-acetylcysteine, NAC, alpha-lipoic acid, and glutathione. The second switch, in this case, which needs to be turned on, not off. Nrf2 you want to shut off. Nrf2 you want to turn on. That switch goes on. That's curcumin, turmeric, broccoli seed extract, sulforaphane glucosinolate. Amazing molecule. I'll talk to you about it. It's been shown to be beneficial in COVID. Strongest phase 2 detoxer you can find. Great as an Nrf2 activator, along with things like green tea extract and resveratrol. Third light switch is NRF3 inflammasomes. Melatonin blocks it. So one of the inflammatory pathways, interestingly enough, for those of you who can't sleep with Lyme, which is very common, can't fall asleep, keep waking up in the middle of the night, melatonin actually shuts off one of these pathways called the NLRP3 inflammasomes. So I'm going to go through the inflammatory pathways. Then I'm going to show you the MSIDS model. I'm going to tell you the points on the MSIDS model that if you're still sick and you're listening tonight, the ones that really have the most bearing that you've got to look into. Basically, what those are is Lyme, Babesia, BART, the famous triad. Those are the ones I'm seeing in almost all of my Lyme patients. And by the way, for Pennsylvanians, if you don't know this tick study that just came out in the last year, your Bartonella population in your ticks just significantly went up this past year. So the prior one I'd seen was about 18%, and it's even higher. So you got a lot of BART that's showing up in Pennsylvania. This is a study that was just recently published. I am seeing a lot of Lyme, Babesia, BART, and when we're using these persister protocols like Dapsone and/or Disulfiram, which I'm going to talk about tonight, even in someone who has had years of therapy with IV Rocephin, you've done a lot of amoxicillin and bicillin and Ceftin and Omnicef and Flagyl and lots of Doxy and Minnow and every drug you can think of. It is the persisters and the biofilms that are playing the largest role in keeping you sick from the point of view of the Lyme, the point of view of the Bartonella, because BART has also been found to be under biofilms. So when we do the protocols that I'm going to share with you, we generally now use things like cinnamon clove oregano oil as our first biofilm agent. We use stevia from Nutrimetics because 𝗘𝗂𝗁 published on it. And then we'll usually use biocidin because that also has some very good biofilm properties. So when I talk to you about these protocols, we're opening up the biofilms. Rifampin is also a drug that opens biofilms apart from going into the intracellular compartment to hit the Lyme and the BART and the other intracellular infections. That's why rifampin is so important when I'm going to show you these protocols. But when you go inside those cells and you kill them off and you open the biofilms with persisters and persister drugs, the only 2 right now being Dapsone, Disulfiram. We will talk a little bit about Hygromycin A and Azlocillin, which are be coming up in the near future, which will be some other options that hopefully will move us along. But if you look at just getting those 3 infections, and when you know how to treat BART or Lyme, you know how to treat Mycoplasma and Chlamydia pneumonia and tularemia and rickettsia because they're all intracellular. You're using combos that are going to go after them. But the trick with doing this for most of you that I've treated is that you usually have multiple overlapping abnormalities on the MSIDS model. A lot of people come in with POTS, they stand up, they get dizzy, they feel like they're going to pass out, or they do pass out. Their heart rate goes up significantly. They have brain fog and fatigue and anxiety. Those are POTS symptoms. They're also Lyme symptoms and BART symptoms. So you have to do sitting and standing blood pressures with an electronic home blood pressure cuff, seeing if your pulse rate goes up standing, if you notice you get dizzy standing. And for example, someone asked the question, that's why I'm talking about it, for other forms of dizziness, the other really common thing we see, a BART tick-borne causing it, is you can get it from mercury toxicity, and you can also get it from people who have reactive hypoglycemia. Half of the American population has insulin resistance with reactive hypoglycemia. So if you are eating carbs in your diet and the bugs love sugar, and you are not having a low carb diet, generally avoiding gluten, wheat, dairy, sugar, you're driving inflammation, and those swings in your blood sugar swings cause fatigue, dizziness, headaches, brain fog, anxiety, palpitations, same symptoms you're seeing with Lyme, same symptoms that are overlapping POTS. So you got to watch out for POTS and hypoglycemia when you're dealing with those kind of constellations of symptoms. We see a lot of autoimmunity. A lot of those autoimmune markers go away when we actually treat the tick-borne co-infections. We see a lot of food allergies and leaky gut driving inflammation. Same inflammatory cytokines you're getting from Lyme. If you have leaky gut with Candida, or you've got an issue with mast cell activation, you're going to keep putting out these inflammatory cytokines, and it's like you've got multiple rivers flowing into an ocean of inflammation. So when a Lyme patient says, I'm tired, I have headaches, I have brain fog, I have palpitations, I can't fall asleep, I keep waking up, I have anxiety, I have depression, right? I have chest pain, I have palpitations. It's all from inflammation. Whether the inflammation is from Lyme or Lyme and BART or Lyme Babesia BART, the inflammation can be from those three and also from leaky gut. Also from the fact that you may have mineral deficiencies like zinc, which drives inflammatory cytokine production, or you're not sleeping at night and your interleukin-6 production is high, meaning you're going to keep throwing off these inflammatory molecules and you're never going to feel well. So when I show you the slides, I'm going to show you a slide that shows you 5 or 6 different things where inflammation is coming from, and then the downstream effects, which is POTS dysautonomia, mitochondrial dysfunction, neuropsychiatric issues, liver issues, right? It's very logical, but you've got to find out where all the sources of inflammation are coming from. I'll talk tonight briefly about diagnostics. I probably don't need to tell you much. Haven't really advanced much, but there are a few advances in the last couple of years. Definitely the phages look like they can be an advance at this point in time. And I know a lot of labs are still working on better PCRs. I still like fish testing. So for those of you who are not sure, do I have Babesia or Bartonella? I suggest you do the IGeneX Babesia fish and Bartonella fish with a Bartonella immunoblot. T-Labs recently had an interesting study that they did on doing some immunofluorescent assays. We did pick it up in a young patient of mine who Stanford wanted to just call rheumatoid arthritis. Of course, it turns out she had negative CCPs, negative rheumatoid factors, not even cytokines that looked like rheumatoid arthritis, but they wanted to give her methotrexate as a young girl instead of, now we treated her with Dapsone. Already her joint pain in her wrist and swelling gone and has stabilized from the rheumatoid. Now we're working on the BART that just showed up in the blood with multiple intracellular antibiotics. And again, where I'm going to show you tonight the protocols, we usually find with BART that it's multiple intracellulars. It's tetracyclines with a macrolide with rifampin with pyrazinamide. And then you throw on some Dapsone disulfiram with methylene blue, does work for Bartonella persisters, and Zithromax methylene blue, what works for BART biofilms. So this all comes from Johns Hopkins University. We'll talk about it briefly tonight. The diagnostics for someone who doesn't know anything about Lyme is actually simple if you know how to play bingo, right? You've heard me probably talk enough about Lyme bingo. 23 OSP-C, 31 OSP-A, 34 OSP-B, 39 83/93. Any one of those bands on an immunoblot, which is not a virus that's stimulating a Western blot with a false 31, immunoblot like the 8 strains that IGeneX does, all you really need is an IgM-IgG immunoblot from IGeneX. Take the Horowitz MSIDS questionnaire, which I'll show you tonight. Look and see what your score is. Look if questions 1 and 2 or 22 are positive. I have day sweats, night sweats, chills, flushing. Question 1. I have air hunger and shortness of breath. Those 2 questions specific for Babesia. So those will tell you that you're going to have to go after the Babesia. Even with negative Babesia testing, those are going to tell you normally, unless you find another course for the fevers, like I've got Q fever, I've got brucella, I've got some other reason why those fevers, sweats, and chills are there, hyperthyroidism, menopause, tuberculosis, non-Hodgkin's lymphoma. Go to my book, How Can I Get Better? Pages 50 to 66 gives you differential diagnosis. So someone who says, I don't know where dizziness is coming from, go to my book, page 59, look up the differentials for dizziness. You'll get it. So Lyme patients, honestly, at this point, I got to tell you, after 35 years, I pretty much have figured out the Lyme piece. The double-dose Dapsone protocol, if you don't have Babesia or Bartonella, and all the aspects of the MSIDS model have been addressed, you're going to be well. I just spoke to one of my patients this morning, sick for years in New York City. 8 weeks of the double-dose Dapsone protocol. We're about to treat his SIBO. He's got SIFO and SIBO. He's going to take, eventually, first he's going to do some natural stuff because someone asked a question about this too. But we do see a lot of leaky gut, a lot of SIBO, right? A lot of food allergies. So you do need to treat the gut. The gut is definitely a source of cytokines, a source of where a lot of these symptoms are coming from for people, especially with mast cell. And those are usually the most difficult patients. So the diagnostics is, do you have migratory pain? Migratory pain, there's only 7 diseases that do it. I'll show it to you. Migratory joint pain, migratory muscle pain, migratory nerve pain. Lyme is the only one that does this. So if you have tingling, numbness, burning, stabbing sensations that are moving around your body, Lyme is the only disease in medicine that causes it. So yes, you can get neuropathy from other causes, mercury, lead, arsenic, autoimmunity, Bartonella, other infections, diabetes, hypothyroidism. I mean, the list goes on, B12 deficiency. But the point is when it's migratory neuropathy, your Lyme is active. So no matter what the tests are telling you, if you've done treatment and your symptoms are still coming and going with good and bad days with no reason, with migratory pain, and you treated the Lyme and the brain fog's coming back and the rest, you didn't get it all. Or you've got BART or Babesia hanging out in the background, or you've not addressed all of the MSIDS factors. You still have POTS, you have leaky gut with food allergies. You just have to work with your doctor going through the 16-point MSIDS model piece by piece, and you will find the answers. The last part of the talk I'll give you tonight will be on Dapsone and Disulfiram. We'll talk a little bit about prevention, and then I'll have more than enough time for question and answers for you. So let me share my screen here with you. Okay, so we're going to do the basics tonight, but hopefully I'll give you enough of the clues of how I've helped my patients that you'll walk away tonight with some real clues as far as why you're sick and maybe where you need to go looking for answers. My conflicts of interest, you heard that I've got a couple of books. The most important of these would be that the views expressed in this presentation do not represent the views of the Tick-Borne Working Group, HHS, or the New York State Department of Health Tick-Borne Working Group that I'm now working on. So as I said, we're going to talk a little bit about COVID-19, the reason being that acute COVID can look like acute Lyme, and long haulers can look like chronic Lyme. And some of you may have chronic Lyme and then gotten COVID. So we're going to talk about these different permutations, what you may need to do to look at the answers. We do have a randomized trial that is waiting at the University of California, Irvine. I saw actually in my email box an hour ago, I heard back from UC Irvine so that we're getting the IRB finished. We should be doing it this year. And we're going to be looking at glutathione deficiency and the MSIDS model in long haulers. Because as I show you in the studies that we've done and what's in the literature, I believe that glutathione deficiency is really one of the primary reasons why people are getting sick from COVID. There are clearly other reasons with risk factors, low natural killer cells, autoimmunity, immune deficiency. There's many reasons. But if you're looking for one major factor that has shown up in the literature, glutathione shows up all the time. We'll talk about prevention. Again, easy diagnosis. We'll talk about the treatment options. And then I just want to finish off briefly about why I decided to write a book on climate change and why it took me 3.5 years to write this novel, which, by the way, is 450 pages in hardcover. And I downloaded it in about 6 months. I sat at a desk and I looked at like a video screen that was blank and listened, and the book just basically downloaded. My wife told me, even though she's not, after 26 years of marriage, I'm not sure my wife finds me funny all the time. She said this book was one of the most humorous books she has ever read, probably in the top 2 she has read. And there are jokes in there, I promise you, that only the Lyme community is going to get. Some of them, you will have a really good laugh. Let's talk briefly about COVID-19. Same symptoms, can be tricky. Fevers, chills, headaches, chest pain, cough, shortness of breath. Now, if you're a Lyme patient who has a cough and shortness of breath, and you don't have asthma, and you don't have allergic rhinitis with a postnasal drip, and you don't have GERD with reflux, right? Because that's 99% of people that end up having coughs and a little bit of wheezing. You're looking at Babesia, right? So Babesia will cause a cough and shortness of breath, along with air hunger, day sweats, night sweats, chills. Those are really classic. I don't usually see a lot of hemolytic anemia with Babesia. Brain fog, you always want to rule out things like B12 deficiency, folic acid deficiencies, mercury, mold. You want to go through the toxins and see why else the brain fog may be there. A lot of times we do find that 2 grams of glutathione, while alkalizing the body, will not only help with herxes, but helps in about 75% of the cases of brain fog. 1/3, I got a little bit of help, 1/3 moderate help, and 1/3, oh my God, my brain is clear, I feel great. And sometimes activated charcoal. I do like the GI detox, which has charcoal and a lot of other binders in it. I find that that also will work well for detoxing the body. We use it a lot for mold with phosphatidylcholine. So the symptoms of COVID and Lyme are really the same. And the reason they're the same, except for, of course, if you have COVID in the lungs where you've got pneumonia or inflammation in the different organs, although Lyme can also do it, right? You can get encephalitis, pericarditis, myocarditis. You just don't see it as often as you see it in COVID. But it's the same cytokines, as I was telling you. So you have to be careful, because there are some people out there, they're going to be diagnosed as long haulers and they've got chronic Lyme. And some people who have vice versa, right, who think they have chronic Lyme and they end up being a long hauler. So you really have to understand that the symptoms coming and going with good and bad days, with migratory pain, where the symptoms change with antibiotics, they get better or worse with a herx, that's going to help differentiate it from a long hauler. And right now, what we know about long haulers, mitochondrial dysfunction, the mitochondria have nothing to protect it against the free radical oxidative stress, the huge amount of inflammation you get with COVID. So that's going to damage the mitochondria. Just like in Lyme, when Garth Nicholson published that 1/3 of the Lyme patients, you give them NT factors, CoQ10, acetyl L-carnitine, NADH, 𝗍, and they'll tell you that their fatigue and some of their other symptoms get better because they had mitochondrial dysfunction, one of the underlying causes on the MSIDS model of why people get sick. The symptoms of COVID, as I said, they overlap, so you really need a differential. So we talked about these 3 switches. NF-κB, you want to shut that switch off. Nrf2, you want to turn it on, and you want to block NLRP3. This switch in the nucleus, NF-κB, the reason, again, I knew about it is just treating Lyme patients, because a lot of the inflammation of interferon gamma, IL-1, IL-6, TNF-alpha, IL-18, all of these inflammatory cytokines you see with Lyme happen when NF-κB is turned on. So we want to shut it down. How do we shut it down? N-acetylcysteine, I start with 600 milligrams twice a day, alpha-lipoic acid, 600 milligrams twice a day, but if you are a diabetic or someone with reactive hypoglycemia, you just have to be careful with low blood sugars, although I take it every day and I have hypoglycemia and it's fine. And glutathione, at least 500 milligrams twice a day. These will all inhibit NF-κB. NAC and alpha-lipoic acid also help your body to make more glutathione. And what's interesting about them is they're antiviral. They were published in the medical literature, NAC and glutathione, way before COVID ever came around. They were published to have antiviral properties against influenza, hepatitis, HIV, and dengue fever. They've shown in viral bacterial pneumonias and ARDS, right, that these may be of benefit because what is the common denominator is low glutathione. So if you're a Lyme patient or a COVID patient, the reason you need to consider using glutathione is because they've been finding low intracellular glutathione levels in people in COVID-19. They found low glutathione levels in people in the ICU and the hospitals. And when you get these high levels of oxidative stress and mitochondrial dysfunction, they also see low intracellular levels of glutathione. So there was a highly significant negative correlation between the level of glutathione you have in the body and how much inflammation, which they're measuring from something called lipid peroxides, and inflammasome activation, which is that third switch I was telling you about, NLRP3 inflammasomes that melatonin is going to help to shut down. The second pathway in Lyme and COVID, the Nrf2 pathway, 4 different substances helps to work on it. Turmeric, you can start with 1 gram a day. It'll go up to 8 grams a day for really severe inflammation. Curcumin has been published in the medical literature to lower every inflammatory cytokine you would ever see in anyone who's got everything from rheumatoid arthritis to lupus to Lyme. My favorite with curcumin is sulforaphane glucosinolate, which is broccoli seed extract. This is a very potent herb, your strongest phase 2 liver detoxifier. So when you're a Lyme patient and you need to detoxify, you're getting rid of all of the toxins, whether it's quinolinic acid, whether it's mercury, whether it's mold toxins, whether you're just herxing and needing to get rid of a lot of those things that are coming out of your cells that are acidifying your body. You need to make sure that your detox pathways are working well. So phase 1 detox pathways, a lot of times you can do that with things like milk thistle. There are products that we use from Zymogen like Medcap's DPO that work on the phase 1, phase 2 liver pathways. But sulforaphane is the strongest phase 2 liver pathway. And if you use glutathione, that's part of your phase 2 liver pathways along with methylation. So certain people definitely need more methylation. You just have to be careful that you're not an over-methylator and that you take methyl groups and you get a little bit anxious. They also showed that vitamin C and antioxidants can be beneficial in COVID, as well as zinc. We find about 18%, we did this in a study years ago, 18% of our Lyme patients are zinc deficient, whether serum or intracellular zinc. Why do you want to have zinc in your body? It mediates your nonspecific immunity affecting your natural killer cells. Your natural killer cells are the ones that fight viruses and cancer. If you have less zinc, you have more cytokines and inflammation. If you have less zinc, you have more susceptibility to pathogens. So you want to make sure when you're doing your workup, you have checked your mercury, lead, and arsenic and aluminum, your heavy metals, but also your minerals, your serum magnesium, red blood cell magnesium, your serum copper and red blood cell copper. You want to check your iodine level, right? And your zinc, both serum and red blood cell. We do these type of serum and red blood cell minerals on everyone. And then finally, this third switch we talked about, inflammasome activation, which is IL-1 beta and IL-18. You can shut that down just using 1 milligram, 1.5 milligrams of melatonin every night. And I've been taking it ever since COVID started to block this particular pathway. So antioxidant glutathione are both important in both COVID and Lyme. So tonight, what we're talking about, and many of you have heard me talk about this before, is the 3 I's: infection, immune dysfunction, and inflammation. It causes symptoms in COVID. It causes symptoms in Lyme. So make sure, and you can check your glutathione level in your blood. It's a very easy test to do. I think LabCorp, Quest, most of the labs will do it. You want to check it to see where you are. But honestly, in this day and age, getting hundreds and thousands of environmental toxins into your body every day, I believe that everyone on this planet should be on NAC and glutathione. I've never seen harm from it. Even people that are sulfur sensitive usually can take it. There's a rare person they can't take IV glutathione because they're sulfur sensitive and they may have mast cell disorder. But glutathione is your primary body's antioxidant. And it's published case studies on COVID-19. We've treated 120 COVID patients with Lyme. It's worked for every one of our patients. I'll show you the protocol in a second. And there's a lot of scientific evidence for using these kind of nutraceuticals, NAC, alpha-lipoic acid, glutathione, zinc, vitamin C, D. I use beta-glucan to stimulate natural killer cells. They'll raise it about 250 to 300%. Again, these are the cells that fight viruses and cancer. And again, using Nrf2 stimulators like curcumin, sulforaphane. So Dr. Freeman and I, and at this point, Dr. Brusacy, James is graduating from med school. Congratulations, James. We published the first glutathione article in the entire world literature on COVID. It's now been cited, at least from a couple of days ago, 155 times. More than any Lyme article I have ever published. And what we showed at that study was within 1 hour of giving glutathione to people who had acute COVID, their respiratory symptoms got better, fatigue got better, headaches got better. It basically helped to shut down the inflammation. And because we know in COVID-19 with the earlier versions, mostly alpha and delta, right? Not so much with Omicron. The beauty of Omicron, which is why, by the way, COVID should be done by March, is that Delta really made it into the lungs and caused a lot of inflammation like with Alpha. But with Omicron, it's just staying mostly in your throat and your upper airway. So it's not making people as sick. But now you've got all these people with natural immunity to coronaviruses. So I'm pretty sure by the end of February, this pandemic is going to be over. We published a second article also discussing the use of ivermectin. It was one of maybe the third article in the literature about that at that point in time. Pierre, Corey, and others had talked about it. And at this point, just so you're aware of the medical politics on ivermectin, there are 26 studies on ivermectin. It is effective. 100% of the studies reported positive effects. And the probability that an ineffective treatment generated from it, from these 26 studies, was 1 in 67 million. Early treatment was successful, estimated reduction 87% in a meta-analysis, and 100% of the 10 randomized trials showed positive effects. So we viewed ivermectin at 0.2 milligrams per kilo once a day for 14 days. As far as I know, for the people that took the Horowitz COVID protocol with NAC and 𝗙𝗵𝗄 acid and GLUT, curcumin, sulforaphane, everything we're talking about, I didn't see long haulers, and we've not lost one patient. Not one of my patients died from COVID. Only 2 were in the hospital in 2 years, only 1 on event, and she was vaccinated, but she had other risk factors. You can find my protocol on cangetbetter.com. So I don't need to go through it. I've talked to you about it, but that's where you can find the protocol. You'll also find, by the way, the IRB that we now have at the University of California, Irvine. And I tried doing an IRB for acute COVID, but unfortunately I couldn't get funding for it. So now let's go into the Lyme talk about biofilms and about persisters. So understand that in the last 7 years, until Stanford, talked about disulfiram and Kim Lewis started talking about biofilms and persisters, and John Hopkins researchers, Kim Young, and also talked about it, I just want to point out, not that we weren't getting patients better. We would use like a cell wall drug. Here's your Ceftin or Omnicef. A cystic drug. Here's plaquenil grapefruit seed extract. An intracellular drug like Zithromax. And, here's some nystatin to keep down yeast. And we would give this Lyme 101 regimen to people, and it helped. It worked. The problem is every time you stopped it, it would keep coming back. And that's because we thought up until about a decade ago that it was the cystic forms, otherwise known as round body, S forms, L forms, cell wall deficient forms. I was the first doctor to look at Flagyl for this. And we did find it was effective. Borson published on it 6 months later. We thought that was the reason people kept relapsing. We just didn't know about biofilms and persisters. We knew that Lyme persisted. We just didn't know it persisted like tuberculosis or leprosy, meaning those particular mycobacterium, they persist, they're very slow growing, they're in biofilms, and that's why you have to normally use long-term therapy. So, in the talk we're talking about tonight, when I'm telling you about oxidative stress and inflammation, whether we're talking about Lyme or we're talking about COVID-19, if you look at all the diseases that are on this list, whether it's Alzheimer's, Parkinson's, heart attacks, rheumatoid arthritis, asthma, cataracts, the one underlying denominator is inflammation. And that's why I'm focusing on that tonight with you. So I want to show you 10 major factors of how you lower inflammation in the body in Lyme, and it'll also help with COVID. We talked about blocking 𝗙𝗵𝗄, activating Nrf2. The next one is blocking activation of glial cells in the brain. Now we know that there are these small cells in your brain called microglial cells. And these are the cells that turn on the neuroinflammation. They're turned on in Parkinson's, they're turned on in Alzheimer's, they're turned on in Lyme disease. How do you block microglial activation? Low-dose naltrexone. So I don't have Lyme. I take 4.5 milligrams of LDN every day. I want to shut off the microglial activation in my brain because I don't want to risk getting Alzheimer's. I got to be alive and smart to figure all this out for you people as the years go on, right? So I want my brain to be sharp. I take glutathione to keep detoxing the chemicals out, but I do take LDN. So LDN, we talked to you about blocking NF-kappa B with NAC, alpha-lipoic acid, and glutathione. Well, LDN also helps block NF-kappa B, and it helps with certain toll-like receptor signaling, and it lowers some of the inflammatory response in the body. Number 3 is particularly important with your diet. A lot of the patients we see, they're gluten sensitive, they're eating too much sugar, they need a trial off wheat, dairy, and sugar, and we see a lot of people with leaky gut and food allergies, fair number with candida, and a fair number with mast cell activation. So the gut, if you're still not well, and you've not figured out where some of this inflammation is coming from, you may want to consider a breath test to check if you have leaky gut, check a zonulin level in the blood, get a 96 food allergy profile, do a histamine, tryptase, and chromogranin A in your blood to start looking for mast cell markers, look at mold toxicity. You want to do all of this to find out where the inflammation may be coming from, because diet and the gut definitely plays a very big role here. So we will heal the gut. We'll use things like 𝗙𝗵𝗁 GHI, a lot of probiotics. We basically don't really ever see cases of C. diff anymore because of all the probiotics we give with Saccharomyces boulardii. So, but the gut is really important if you're looking for answers. We talked about the minerals. Those are needed for detoxification, for inflammation. We talked about sleep. Now, I don't use Ambien, Lunesta, and the regular drugs. If you look at my book, Why Can I Get Better? How Can I Get Better? We use things like doxepin 10 milligrams, trazodone 100 milligrams. Maybe we'll use a little bit of Lyrica. We're going to use drugs that are not normally used for sleep. Flexeril, cyclobenzaprine 5 milligrams, which a long half-life to keep people asleep. We want to do this because we want to get you into stage 3, stage 4 non-REM sleep. You can get deep REM sleep. So it's very important if you're using benzodiazepines and some of these other drugs, you want to do your best to try and taper off because they're really not great for your body. And Lyme patients will get to sleep. We use lots of herbs like valerian root mixed with melatonin, mixed with 𝗙𝗄𝗁. You want to check your adrenals with your DHEA cortisol because some people have high cortisol at night. They mean a little bit of phosphatidylserine. But we find when we come by herbs, Serenity PM, 𝗙𝗁𝗁, melatonin, valerian root, right? We mix these with some medicines, we generally can find that we can get these very resistant Lyme patients to sleep. Number 6, the infections. We're going to talk about that in a second. The triad Lyme, Babesia, Bartonella. We'll talk about, again, from my perspective, I think we pretty much got, believe it or not, the Lyme under control. It's the Babesia and Bart where we're having the problems, I'll explain. Detoxification, very important. You need at least 2 liters of fluid a day. If you got an infrared sauna and you want to sweat through the skin, these bugs hate the heat. That form of detoxification, raising your body temperature, even can make the antibiotics more effective. If you go back in the medical literature, like 30 years ago, they found that when you rose the body temperature just 2 degrees to like 101, 102, and you gave them IV Rocephin, the Rocephin was like 4 to 16 times more effective at a higher body temperature. And that's why some people, of course, go to Germany to do this, although in my opinion, you're not going to be as effective doing hyperthermia if you're not opening up the biofilms or you're not using persister drugs. Because for me, that's really where all of the benefit we've seen lately has really come from. Balance the hormone cytokines microbiome. Get your adrenals checked if you're chronically fatigued with a DHEA cortisol test. Everyone checks the thyroids. If you're a man, your libido is off, check your testosterone. A lot of the men that come to see me have low T, basically because these inflammatory cytokines we've been talking about go up to your brain, to the HPA axis, the hypothalamic pituitary axis, and they basically shut down luteinizing hormone and you don't make testosterone. Some women, they also have problems with their periods because it shuts down the FSH and the LH. So the stuff to really look for men is testosterone, do the sex hormones, but don't forget the adrenals. The adrenals is absolutely essential. Cytokines microbiome, we talked about that you just got to get great probiotics in. Our triad, by the way, that we've had great success is Theralac, Orthobiotic, and Saccharomyces boulardii. We'll sometimes use Probiomax from Zymogen. Their 350 is fabulous. We'll use the Orthobiotic 100 billion. We have lots of different ones we use. And even the spore-based probiotics for people who have SIBO, there's been some published studies on using these immunoglobulins and spore-based probiotics that can help with SIBO, apart from using the regular drugs like rifaximin and neomycin. Heal the damage to the body. After I do double-dose Dapsone for 8 weeks, I usually will give people a 1-month mitochondrial regeneration. Why? Because whenever you're taking any of these antibiotics for Lyme, or even any drug, any pharmacopoeia you are on, or living just on this planet, with all the free radical stress and all of the pollutants getting into your body, your mitochondria are not like the DNA that have histones protecting it. You have nothing protecting your mitochondria. I do a mitochondrial regeneration twice a year. I'm actually finishing one up now. I do a month of ATP 360, 3 a day from Research Nutritionals. CoQ-Power, 400 milligrams twice a day from Research Nutritionals. Acetyl L-carnitine Carnitex, 2 twice a day from Zymogen. And Enata, NADH, 5 milligram once a day. Those 4 supplements I find are very good for mitochondrial regeneration. So if someone does a regimen and you take them off and they're still sick, just know that your Dapsone or Disulfiram may have knocked it, but they may have Candida. You may need to ask them about gas and bloating and how their gut is doing with carbs. Candida can look like Lyme. Fatigue, brain fog, joint pain, muscle pain, just not migratory symptoms that come and go, and it's diet dependent. But Candida can look like Lyme. 10% of my Lyme patients, I give them a course of fluconazole when they're done with these antibiotics, and they feel tremendously better because they had an overlapping Candida issue, even though I gave them nystatin, and even though I gave them essential oils like cinnamon, clove, oregano, and biocidin that keeps down Candida. Maybe they took in a little too much carbs or the antibiotics just did what it did. But Candida and mitochondrial dysfunction, really important when you're done with these protocols, because you may have actually been more successful than you think. Finally, heal the damage to the mind and emotions. Approximately 1/3 of the people who've come to me have been abused. Physical abuse, emotional abuse, and sexual abuse. And so I will tell you that if you're one of these people who is the walking wounded, and the reason I know you so well is because, number one, for those of you who don't know, I am a medical empath. I feel into people's bodies and I know exactly what is going on. And I can tell you that it's pretty rough to get over Lyme and these tick-borne infections if you have been so traumatized emotionally that you believe somehow in your subconscious that you don't believe you deserve to get better. These are the cases where you need the anti-hopper DNRS. Yes, of course, a therapy, but you're going to need things like EMDR. You're going to need things like neurofeedback. Neurofeedback can be very effective. My wife had had some PTSD reactions when she was young, very difficult childhood. I've had the same thing, difficult childhood. That's how I can kind of vibe you out and understand it with compassion. It's because I've gone through it. Not certain forms, but definitely I've understood emotional abuse and physical abuse. So I am with you, all right? I'm a human being like the rest of you, and that's why I understand this so well. You need to get help. You cannot stick this under the rug if you are trying to get better for Lyme. So I have compassion. I understand you're suffering with it, but please help us out there. Go get some therapy. Look at EMDR, look at neurofeedback, look at biofeedback, look at cognitive behavioral therapy, but get help because your mind and body work as one. You cannot do this without working the mind at the same point. I don't need to spend a lot of time with diagnostic testing. Most of you know it stinks. Not much better over the years. Labs vary. You've got all these different species of Borrelia. That's why I use the immunoblot from IGeneX, which checks 8 strains. That is my go-to. I do an IgM, IgG, immunoblot from IGeneX. And if any one of those Lyme bingo bands I told you about, 23, 31, 34, 39, 83, 93 shows up, and you fill out the questionnaire that I'm about to show you, you have a high score over 63, and you've got good and bad days where you've got migratory joint pain, and you've got day sweats, night sweats, and chills with air, hunger, and cough. I have diagnosed you with Lyme and Babesia. Not even a doubt. So even though the tests are not perfect, if you use the questionnaire, look at the migratory symptoms, right, and just do some easy testing, Babesia fish, immunoblot, you can easily figure this out, even though the testing, there's a lot of problems. In our study that we published a couple of years ago, only 20% of our chronic Lyme patients had EM rashes. So not surprising, and Johns Hopkins, other researchers have found the same thing. You can get circulating immune complexes in the spinal fluid, which is sometimes why they're negative. Borrelia can subvert a B-cell response. For those of you who are sick and have not checked your immunoglobulins and your subclasses, you need to do it because in the studies we've done, 7% of our population had chronic variable immune deficiency, and 85% had immunoglobulin deficiencies, usually in subclasses 1 and 3, which are the ones you need to phagocytize and eat up those bacteria and kill them. So you need to get those checked. Some people need to get a Pneumovax to find out if they make antibodies, because sometimes the immunoglobulins are normal and they don't make antibodies to a pneumococcal vaccine. And some people will get a Cunningham panel, look at anti-dopaminergic antibodies to also see whether they might need something like IVIG, apart from having chronic variable immune deficiency or very bad neuropathy. So just keep in mind that's very, very important if you've not done it. So most labs use the B31. If you get Quest LabCorp, 1 strain. IGeneX Western blot used to be 2 strains. Now the immunoblot is 8, which is why you just go straight to the immunoblot. So how are we making the diagnosis? Well, I probably do the C6 ELISA a little bit more because it checks 3 strains, Borrelia abscelli, Borrelia guarini, and Borrelia sensu stricto. So I usually will do the C6 before the ELISA, but I will tell you, the C6 can be negative and the ELISA can be positive, or vice versa. So I've seen ELISA positive, C6 negative, IFA negative, or immunofluorescent assay positive, ELISA negative, C6 negative, Western blot positive. All the permutations are possible. The trick is look at the bands on the immunoblot. These bands that are on an immunoblot, these 5 I'm telling you about, are Borrelia specific. So if you are sick and any one of these bands are showing up in the blood, you have been exposed to a Borrelia species. So that's really, really important. And then at this point, I fill in the gaps with fish testing, Babesia fish, my favorite for Babesia, Bartonella fish, one of my favorites for Bartonella. Unfortunately, in Newark, we can't get it. So Galaxy Lab is certainly an excellent lab. Again, T-Labs just came out with one, needs to be looked at. But since Marna Erickson is doing some of that work with immunofluorescence, I'm sure it's going to turn out to be a very good lab. So here's the MSIDS questionnaire. I think most of you know it. This took us several years and 1,600 patients to publish this. This is the only validated early Lyme questionnaire that's out there. It's got 4 sections, and I think most of you know it. I don't need to spend a lot of time on this. The point being, a score greater than 63, high likelihood Lyme's there, especially if migratory pain is present. Now, I told you earlier, there are only 7 things that cause migratory pain. So if you go to your doctor and you have migratory neuralgia, tingling, numbness, burning, stabbing, that's automatically Lyme because nothing else causes it. But migratory joint pain or muscle pain can be seen briefly is the point, with acute rheumatic fever or Crohn's, gonococcal arthritis, hepatitis early on, reactive arthritis, Reiter's triad, lupus, right? Possible. But honestly, in day-to-day practice, 99.999% of migratory pain is Lyme. I mean, that's just what it is. But if you want to remember what these 7 things are, this is the slide, and it's in the study that we published. So the factors that were the most important to discover if someone had Lyme was neuropathy, their cognitive dysfunction, the brain fog, memory problems, musculoskeletal pain, oftentimes, again, migratory, fatigue, dysautonomia POTS, and finally, cardiorespiratory like chest pain, shortness of breath. So this was validated in 1,600 people. It has an 87% accuracy. It is better than the 2-tier test, which is about anywhere between 50, 58, 59%. And again, a score greater than 63, high probability. 45 to 62, probable Lyme. 25 to 44, possible. Now, I will tell you, I've still seen people with a 28 score that tested positive for Lyme. Just because it's low doesn't mean you can't have it. You may not have just a bad case of it. And then 1 in 22, as we talked about, is Babesia. So this was adapted from Dr. Boroscano's questionnaire years ago, but what we did is we put in frequency and severity, scored it, and then added in 3 other sections. So let's finish up the talk with this 7-point action plan for treating Lyme. So first of all, just know that when you're trying to get better from this disease, it is not constantly checking immunoblots and PCRs and fishes that tell you how you're doing. It's taking a clinical history. Symptoms drive diagnosis and treatment. So what we do when patients come to our practice is we use that first questionnaire, the one that you saw, the 38-item questionnaire, and every time they come to us, they fill out the questionnaire. So this way I know how their Babesia is doing. Oh, your day sweats and night sweats were severe. I gave you Mepron, Zithromax, Bactrim, some Cryptolepis, and Artemisia. Oh, and now they're mild. Okay, it's not gone. They're mild, but it's better. I'm driving down the load of the parasites, right? So I can, this way from month to month, I can look at how the symptoms are varying, and the treatment regimen is based on how your symptoms are varying. Lower inflammation, we talked about it in these different pathways while detoxifying, repairing the damage. That's some of the mitochondrial, right? So we talked about these other rules of sleep, proper diet, looking at leaky gut, candida, mast cell, food allergies, very important, and the wounding. But this is the slide I was telling you about earlier. If you want to figure out where the sources of inflammation are coming from, of why you're sick, this is the slide that's going to pretty much tell you where you need to look. Now, under chronic infections, the rule of thumb, at least in my practice, is Lyme, Babesia, Bart. Now, that doesn't mean you can't have mycoplasma or tularemia or rickettsia, which are also intracellular, like brucella. But most of the regimens where you're going to use a tetracycline rifampin, like doxyrifampin, it's going to cover tularemia and rickettsia and Lyme and mycoplasma. So the advantage when you're using something like the Dapsone protocol with a tetracycline and rifampin is that you're hitting all these intracellular infections at once. Number two, the intestinal bacteria, the dysbiosis, certainly is possible. You can do a CDSA, a comprehensive digestive stool analysis. Take a look and see what's going on in the gut. But I do like the breath testing for leaky gut, zonulin testing if you can do it in your state, 96 food allergy profile, and definitely keep looking for mast cell. The way, by the way, you know if you may have mast cell, if you walk into a room and you smell something, you have an immediate reaction, or you eat a food and you have immediate reactions with itching, sneezing, wheezing, that's mast cell reaction. That means your mast cells and basophils in your body are unloading all of the histamine and these inflammatory cytokines. The fourth, you got to get to sleep. If you don't get to sleep, and again, look at my books, it talks about all the different drugs and herbs. If you don't get to sleep, the inflammation is not going to shut down. You cannot possibly tell someone how well they're doing after Dapsone if they're not sleeping, because they're going to have fatigue and brain fog and even fibromyalgia symptoms. Environmental toxins, everyone gets checks for heavy metals in the bloods. We don't do the 6-hour urine DMSA challenge much anymore because it turned out that the medical boards didn't like using that for chelation. But I will tell you, I just had a Lyme patient, actually it's a physician who has this, who was eating a lot of fish, complaining of ringing in the ears with tinnitus, and didn't know what it was, and the mercury level was off the wall, and of course the Lyme was positive, and now is getting better, right? So environmental toxins, go after the metals and mold, and if you're really environmentally sensitive, you can get LabCorp to do other panels for things like PCBs and dioxins. They will do a lot of solvents. I think LabCorp actually covers it on most of the insurance. So look at PacTox Lab, look at Genova. There's other labs that will do functional medicine evaluations for this. And we talked about the nutritional deficiencies, important, magnesium, serum, RBC magnesium, as we talked about. So now these inflammatory sources, you got all these streams of inflammation, they're having a downstream effect on the body. They're lowering your testosterone. They're throwing off your adrenals. They're causing POTS with low blood pressure. They're causing mitochondrial dysfunction or resistant pain syndromes with small fiber neuropathy or autoimmunity. A lot of these autoimmune markers, ANAs, rheumatoid factors, anti-thyroid antibodies, anti-ganglioside antibodies, these are from Lyme or affecting the myelin sheaths in the body. You get a lot of autoimmunity with Lyme, but it's not the primary reason why people are sick. Now, that's not to say that you can't have an autoimmune disease like rheumatoid arthritis and have Lyme, or have Behçet's disease and Lyme. I have one of those patients. But overall, most of these autoimmune markers get better as long as you're treating the Lyme with these persistent biofilm protocols. So the common denominator underlying these different etiologies, these 16 points on the MSIDS map, is usually multiple infections, Lyme Babesia Barrett, toxins, often heavy metals and mold, leaky gut with food allergies and mast cell, very common, nutritional deficiencies, very common, get them to sleep, and you're usually going to find that a lot of these people do get better as long as their POTS is treated. So the inflammation, again, it's coming from multiple sources. And you can get neurotoxins that are produced from the Lyme, like quinolinic acid. So, you know, when someone says, hey, doc, I took 2 grams of glutathione and my brain fog cleared, I don't know whether that's quinolinic acid or whether that's some other environmental toxin because we've never actually done the study. But it does work in a significant number of people. And that's why early on I said, go to like GI Detox, which has bentonite clay, charcoal. You can do it with some glutathione. Just the clay and charcoal have to be 2 hours away from everything you're taking so it doesn't bind it. But a lot of times it'll pull a lot of those toxins out very efficiently as long as you're sweating and you're drinking enough fluids and you got fiber and the gut is moving properly. You just got to work all the different detox pathways at once. So the bacterial infections we're seeing most often, apart from Lyme, the one you now really have to look for is relapsing fever, hard tick relapsing fever, Borrelia miyamotoi. Why am I stressing this tonight? Is because Borrelia miyamotoi will not test positive on your classic Lyme test, although you will get a false positive C6 ELISA, where you may think you have Lyme and the C6 is actually indicating you have hard tick relapsing fever, Borrelia miyamotoi. So IGeneX does a relapsing fever panel. And by the way, no, I have no financial association with IGeneX. I just think they're a great lab. So I would do their relapsing fever panel. I think it's a great panel to look for it. But you can also get Borrelia miyamotoi through Quest. You can get it through a lot of your locals. But right now, I've never gotten a PCR positive from Quest. And a lot of people are being exposed to it in tick bites. So just know that I think there's kind of an unknown with this particular relapsing fever, because what prior studies have shown is that under the biofilms, when you have Borrelia burgdorferi sensu stricto, and it's right next to a relapsing fever Borrelia that keeps changing its outer surface proteins to fool your immune system, those guys are having spirochetal sex underneath your biofilms, and they're changing their forms. They're changing their genetics. So, you know, the relapsing fever, the way it avoids your immune system is it keeps changing the outer surface protein. So think about if you now have relapsing fever spirochetes mixing with your Lyme spirochetes under biofilms, and Garth is one of the people who talked about this early on, I think you're going to probably find that the Lyme is changing over time. But fortunately, we still have seen the Dapsone and Disulfiram protocols help in most of these cases. Ehrlichia anaplasma, we check. It's not usually considered chronic, but people who have anaplasma who are not properly treated do become immune deficient. Bartonella is by far the biggest problem I'm facing right now because there are like over 36 different species, and it is very difficult to kill. I'll talk to you a little bit later about some of the different treatments that we're using. I talked briefly about it earlier with multiple intracellular drugs. Babesia shows up in 90 to 95% of my patients. So again, day sweats, night sweats, chills. The problem with Babesia, we have to rotate in multiple anti-malarials. I don't find Mepron Zithromax work the way it did 20 years ago. So it's not like I might not use it, but I don't find a teaspoon of atovaquone Mepron works so much. If I do it, I'll use 2 teaspoons BID with a high-fat meal. I'll give it with Zithromax 250 BID. I'll usually use a sulfa drug like Bactrim or Dapsone. I'll usually use, again, things like 𝗙𝗵𝗄𝗏 and Artemisia because I'm using multiple anti-malarials at once to knock down this parasitic load. And a lot of my patients just stay on Malarone. They stay on 𝗙𝗵𝗄𝗏 because they just have to keep knocking it down. Today, I gave somebody a coarctim pulse. Coarctim is artemethyl-lumefantrine. It's Riomed in Europe. We use 3-day pulses, 3 on, 11 off, 3 on, 11 off. You'll find it in my book, but some Babesia patients that don't respond to the classic therapies, they will respond. Now, I have brought out an old drug I used to use years ago, which is lariam-mefloquine. Difficult because it's a very long half-life of like months and can affect the QT interval. Same with the new drug that recently came out, tafenoquine, which I've tried. They were supposed to say, oh, it's a great Babesia drug. Variable. I would not say I've seen miracles using tafenoquine, but you can kind of use it in the Babesia armamentarium. Viruses. There's a bunch of people that have been exposed to West Nile, which is a flavivirus like the Powassan virus. One of the things you need to know about flaviviruses is that they can persist in the body. Zika virus can persist. West Nile can persist. Powassan, we don't know, but why am I bringing this up? The studies that were done by Connie Knox and other researchers in the last couple of years is that if you are living in a Lyme endemic area, you have 10 to 16% of these Lyme patients who are now testing positive for antibodies against Powassan virus. Now, you might not have gotten neuroinvasive Powassan, which thank God only 1 in 150 get where they die from the disease because there's no cure at this point. But we don't know at this point if you get a virus like Powassan or West Nile, which are flaviviruses, where you may have a chronic viral infection. So if I give ivermectin, which has an antiviral property, and someone takes ivermectin, and not for COVID, and it's not a great Babesia drug. Some docs use it, but I don't really think it's great. And a patient says, oh my God, I feel fabulous on ivermectin. What is that telling me? You've got an underlying viral infection that we have not yet figured it out. Whether it's HHV6 or whether it's Epstein-Barr or whether it's CMV or whether it's West Nile or a flavivirus, I don't know what it is. I just know that if you are responding to ivermectin or famciclovir, you got a virus that's interfering. And in some of the Lyme patients that don't get better, the viruses are playing a role. In my practice, I don't think it's more than maybe 5 or 10% maximum. It's still Lyme, Babesia, BART, POTS, leaky gut, mast cell, getting to sleep. It's all the stuff I've been telling you about. But don't forget the viruses, and don't forget occasionally an antiviral trial and looking for PCRs in the blood. We talked about Candida, very, very important to look for it. Check all of your autoimmune markers. You can follow them with your Lyme treatment. Toxicity, we talked about metals and mold. We talked about allergies, nutritional deficiencies. Mitochondrial, we talked about it. We talked about psychological dysfunction. The neurological dysfunction, I mean, it's very common. Neuropathy is 95% of my Lyme patients. And the question on dizziness, I think I answered for you. You need to be checked for POTS. You need to make sure you don't have reactive hypoglycemia. You need to make sure you don't have an eighth nerve issue with an eighth nerve benign tumor. I mean, there's all kinds of things it can be, but usually POTS is going to be probably on the top of the list with hypoglycemia. Many of these things, by the way, do get better after persister protocols with Dapsone and Disulfiram. Endocrine, as we talked about, do all the hormones, especially adrenal, get them to sleep. POTS, very important. We talked about the GI. Elevated liver functions can happen from all the different infections. Pain syndromes can happen from Lyme, Babesia, Bartonella. And again, if you're deconditioned and you've been out of shape for a while, you may want to work with a physical therapist that can be very useful. So when we did the initial Dapsone study, part 1 of the precision medicine, followed by part 2, where we looked at all the MSIDS map, you'll notice when you look at all these 16 variables for MSIDS, most people had like most of the MSIDS abnormalities. Now, mitochondrial didn't show up on this one, but it's only because the people got so much help with Dapsone, we couldn't tell what the mitochondrial regeneration was doing. So keep in mind, you are going to normally have multiple factors on the MSIDS map keeping you sick. So we talked about the diagnostics. We talked about persistence. Persistence really is for Babesia, Bartonella, as well as Lyme. And of course, the problem's just with healthcare politics, where, you know, we wouldn't be where we are now if the politics just had been more sane. So there's all these studies on persistent Lyme. I think you know probably if you've been following online with change.org and some of the stuff that comes out. I mean, there's got to be 700 articles at this point on why Lyme fails because of treatment failures from persistence. Anybody that's been following the literature for years should not be doubting Lyme persistence, right? And when we did this first Dapsone study in part 1, 14.5% of our patients with Lyme were PCR positive, despite every antibiotic we threw at them. This, by the way, was before Dapsone. But it didn't matter whether it was doxy or rifampin, whether it was ceftin or IV Rocephin. I've had patients do 1 year of IV Rocephin, not with me, but with other doctors, come off the Rocephin and in 2 weeks crash, go on double dose Dapsone and be 4 years in remission. IV Rocephin is no longer being used in our practice since we discovered these persister drugs. That's the beauty and the hope for the Lyme community. But we saw Babesia persist by PCR on fish, lots of Bartonella that persisted by fish and PCR. We saw occasionally a tularemia that would relapse with brucella by positive agglutination. I don't check Mycoplasma species so often. It should be treated by a lot of these intracellulars we're using. And we've seen viruses relapse like herpes virus 6. But it's really the biofilms, the work that's been done by Dr. 𝗂𝗵𝗄, right? The one that's been done by Kim Lewis. If it wasn't for these great university researchers, John Hopkins, I wouldn't have been able to come up with the Dapsone protocol the way that I did. You know, this one study that was done years ago from Hopkins really says it all. These stationary phase biofilm persister microcolonies is what's driving inflammation. So not that the inflammation can't come from all those things I talked about, leaky gut and Babesia and the rest, but it's these persistence, these persisters that are in the biofilms, these forms that are dormant, right? When you use Rocephin or ceftin or amoxicillin, it only works if the Lyme is active and actively replicating. It doesn't work for persisters. Neither does Flagyl, neither does the regular intracellular drugs. You have to use a persister drug if you want to get the persisters. Right now, we've only got Dapsone Disulfiram, but I do everything backwards. I first figured out that Dapsone worked, and then we went to the lab and we looked in culture to find out why it works. And it turns out that Dapsone, in combination with these intracellular antibiotics, doxy, rifampin, works very well against the biofilm form of Borrelia. So if you look at the bottom panels, if you look towards the right, which is K, Dapsone, doxy, rifampin, you'll notice that after 72 hours on these 3 drugs, look at the size of the biofilms and the persisters. If you gave doxy alone, rifampin alone, ceftin, you'll notice the biofilms are a lot bigger. The biofilms are very small when you do those 3 drug combo. Now, if you added azithromycin, it got about 3% better. So what we found with this study is Dapsone alone, or doxydapsone, or doxyrifampin dapsone, or doxyrifampin zithrodapsone, 4 intracellulars. And again, take home message for tonight, these bugs, where they're hiding, were causing the inflammation, Lyme, Bartonella, intracellular compartment. That's where most of them are hiding, and that's why these drug regimens are so effective. And the beauty is it goes after a lot of these co-infections all at the same time. Last year, about a year and a half ago, we finally published the efficacy of double-dose Dapsone combination therapy. This is the regimen that finally got my wife well. So this is an 8-week protocol, 8 weeks. We had patients that were sick for 10 years, 20 years, 30 years, failed every regimen known to mankind, and went in remission for 1 year or longer with an 8-week Lyme protocol. That is unheard of in the Lyme community. And that's why, please, you need to go forward and tell people that there is hope. And when I add disulfiram, by the way, in some of these people, very interesting, some of these people say, hey, doc, you added disulfiram. And all of a sudden, some of the symptoms that wasn't gotten by the Dapsone got better, right? Or they were on disulfiram, and then I add Dapsone on, and they say the same thing. It's like these two persister drugs in combo sometimes work very well together. Now, I don't have a published study on it, but we have a study that I'll be publishing later this year, just like I learned about double dose Dapsone because one of my patients made a mistake. Thank you, God, for making him make a mistake. And then I learned about it. A patient of mine was about to go into her second month of double dose Dapsone. She got a letter from her husband that he decided to divorce her. She got so upset, instead of taking double dose Dapsone, she decided to take quadruple dose Dapsone. So she calls me on the phone after 4 days going, oh my God, I feel terrible. I'm vomiting. I am sick as a dog. What is going on? I said, well, what are you taking? Well, I'm taking 200 of Dapsone twice a day. And I went, oh my God, you're taking too much Dapsone. Get off of it. She's now 9 months in remission. She never finished the second month of the protocol. She did 4 days at 400 milligrams. Okay, I said, all right, God, Buddhas, Bodhisattvas, whoever is communicating with me here, you want me to try pulsed high-dose protocols for Lyme patients, and that's what we did. So we tried it on about 40 patients. I'm going to be publishing the results. I'll just give you some preliminary ideas on this. What is shown to me doing the study is that it takes multiple courses of this pulse to work, but there are patients that they might have had 1 or 2 resistant symptoms. I have a kid in California. His cognition was horrible for decades. After his 3rd course of this pulse, his cognition is significantly better. It didn't happen with the 1st or the 2nd. It happened with the 3rd. I had another patient. She was at 55% of normal. After double dose Dapsone, she was relapsing. She has BART. I put her on the quadruple Dapsone for 4 days. She's at 98% of normal. 4 days. So the problem is the tolerance needing Zofran and stuff for nausea, but I will have a publication for you later. But the reason I'm telling you this is what has become obvious to me as a clinician who sees Lyme patients all day long. The higher the dose of the persister drug or the better we're opening up the biofilm, that's where the answers are lying, at least with Lyme. I can't talk about BART specifically, but some of these patients do have overlapping BART and they do seem to be responding, although half of them have been on disulfiram, lower dose. I don't use high dose anymore, 125, 250 maximum. Probably 125 is my average these days. And I will mix that with Dapsone, and I find that sometimes it's a very good combo. So in any case, it is an effective combo, but it's not great if you're active for BART. When we published the study, the 7 people that were BART fish, not one of them went into long-term remission. They may have gotten better, but no long-term remission. Whereas the Babesia, if you were Babesia fish positive, you had a 50-50 shot, which is roughly the efficacy of this protocol. You've got roughly a 50% chance of long-term remission if you don't have active Babesia BART, and that's the best we've had in the Lyme community for the last 3 decades. So when you're looking at all these drugs that have been out for Lyme disease for these decades, log phase is actively dividing forms. That's your penicillins and your cephalosporins. That's your IV vancomycin. Or your round body cystic forms, cell wall deficient S forms. That's your plaquenil, grapefruit seed, flagyl, tinidazole. I don't really use flagyl, tinidazole much anymore. I don't need it. Intracellular, tetracyclines and rifampin is my favorite combo. It seems to work best, and it works really well when you start mixing it with zithro and pyrazinamide for Bartonella, and you throw in a little methylene blue because the zithro methylene blue works on BART persisters, and you throw in disulfiram, which does have an effect on BART. We're making some headway. I have cured BART patients, but the problem is I don't want to give the cure to anybody because the cure, when I finally did do it, required IV gentamicin. And I will not use IV gentamicin because of the possible effect on the 8th nerve. I only gave it to my sickest Bartonella patients that were out of every option under the sun. Some got better, but 2 patients basically got some vertigo issues, even though the peaks and the troughs were completely normal in the bloodstream. So I'm afraid to use the drug, but I will tell you, if somebody can come up with a better form of gent, and I know they're around, and one study that needs to be done, it was published about 2 years ago, when they were looking at the biofilm busters like peppermint oil, apart from the clove oil and oregano oil and cinnamon oil, they showed that these essential oils will lower the MIC, the minimum inhibitory concentration of gentamicin. Why is this interesting to me? Because maybe there's a way in Bartonella, I mean, somebody just needs to do this study, first in culture, and then eventually a human trial, instead of then using the usual dose of gentamicin, which is like 1 milligram per kilo every 8 hours. Maybe you can get away with a half or a third of the dose of gent by using the essential oils like peppermint, because this published study showed that it lowered the MIC, the amount of gent you actually would need to use to kill these bugs. So that's the best clue for any researchers that are out there listening. That's the best clue I got, because I found when the gent was added to a 4-drug intracellular, and some of these patients had also done disulfiram, which I think is better for BART than Dapsone, but some of them did respond to this higher dose pulse Dapsone when it was high enough. I do think that that is going to be an answer for BART, but we have to find a safer way of being able to give the drug. And then finally, the stationary phase persisters, that's Dapsone, disulfiram, azlocillin, daptomycin. I tried it a couple of times, very expensive. I don't like the side effects of the drugs. And despite John Hopkins researchers saying that it'll completely eliminate the persisters, I didn't have the same experience. The 𝗪𝗁𝗏s were terrible. So, you know, I've used disulfiram, and the last one that Dr. Liegner published on disulfiram, 71 patients, 2 groups, you know, his long-term remission rate was, you had to be on it for, 6 months to 18 months, up to a year and a half, and you had a 36% long-term remission. I've got roughly a 50% remission with an 8-week Dapsone protocol. So I will tell you, I think the Dapsone makes sense from the point of view of it takes forever to work people up on disulfiram, but if you don't want to mess around with the microbiome at all, I don't find it's really a problem as long as you take enough probiotics. Disulfiram is certainly from that perspective is better, but the 𝗪𝗁𝗏s on that drug and the side effects of it are bad. And even though people don't like the side effects of Dapsone, I've been able to keep down the methemoglobin levels with compounded methylene blue, 50 milligrams twice a day or 3 times a day, 2 grams of glue 2 or 3 times a day. It keeps down the methemoglobin. It is not an issue. The anemia can be kept down with massive amounts of folic acid. So I figured out how to get around the side effects of Dapsone. If you've been worried about using it, you really should speak to your doctor, because the methylene blue and glutathione and high-dose folic acid is making it very tolerable for people who do it. So in this next year, I'm hoping we're going to see something about azlocillin. We should be seeing something soon about Hygromycin A, which comes from Kim Lewis's lab. He found it's efficacious without disturbing the microbiome. Again, we need clinical studies. We also need clinical studies on azlocillin. It does kill log phase, 7 to 10 day stationary phase persisters, and found that with cefotaxime, it killed the tolerant 𝗵𝗿𝗄, but I'm not sure what they're referring to with doxy tolerant, because usually there's not been any resistance to doxy that I've ever seen. And as I said, I'll have this high-dose pulse Dapsone study done where I'm talking like 4-day pulses, 7-day pulses of drugs, like trying to get shorter and shorter, that it's not the length of time on the antibiotics that's the issue. It's the dose. It's opening up the biofilms and getting enough of that persister drug in there to lower the persisters, which is driving, probably in most patients, the majority of where the inflammation is coming from. So let me just finish off with just 1 minute on climate change. Climate change is causing ticks to now come out 3 weeks earlier. This comes out from Rick Ostfeld's Institute for Ecosystem Studies. And as the global temperatures are rising, and it's 1.1 to 1.2 centigrade here in North America, but in the Arctic, it's 2 to 5 times higher, which means that the permafrost is melting, which contains twice as much carbon dioxide as in the atmosphere right now, and large amounts of methane. And methane is 30 to 70 times or 80 times more efficient in heating the planet than carbon dioxide over shorter periods of time. They just discovered several weeks ago that there's a glacier, the Thwaites Glacier, which is in West Antarctica. It's got an ice shelf and it's starting to crack. If this ice shelf comes off and the Thwaites Glacier comes off, you're looking at sea level rise of somewhere between 3 to 10 feet. Now, this is maybe happening in the next decade, which is you can kiss New York City, Miami, Bangladesh, and any coastal cities goodbye. This is not science fiction, folks. Go look up Thwaites Glacier, what is happening in Antarctica. In the book that you're about to see, it's about to be released in 5 or 6 weeks. I have geoengineering solutions that I found that no one is talking about in the mainstream media. And I believe that unless you start to cool Antarctica and chill out this glacier, we're going to end up with problems, because based on COP26, the world leaders are doing nothing. They're all making promises, and the levels of CO2 went up to 420 parts per million this year. The last time the Earth saw 420 parts per million CO2 was during the Pliocene era 3 million years ago, when the Earth's oceans were 30 feet higher. We are now at that level right now. We are running out of time. So those of you who follow me on Facebook and keep watching all these posts on the climate and Lyme, the reason I keep telling you about the climate, this is the greatest existential threat humanity is facing. We are in big doo-doo here, folks. You've got to get on the line with your congressmen, your senators, and your people to tell them they've got to pass this Build Back Better Act and get off their butts and get something, because we are not prepared in the United States for the electric grid to go down. Look at Texas, of what happened the year before during the snowstorm. We are not prepared for what is coming. I need to prepare you. I'm not here to scare you. I have solutions. There are solutions in the book. There are solutions. The problem is they are not being instituted properly. So you need to educate yourself, because this is going to affect you and your children and future generations. And the kids who are coming into my office with Lyme, they would get over Lyme from double-dose Dapsone, and I'd say, great, what are you going to do with your life? And they said, nothing. I said, what do you mean nothing? They said, well, the world's going to end. Why should I go to college or get a job? Now, if you know me well enough, I'm not one to miss small little things that come in, or big, signs. This was happening in my practice over and over again, that the younger generation was coming in with climate grief. And at that point in 2018, I started looking into the literature, and these kids were right. We were in trouble. So when I started writing this book 3.5 years ago, I made predictions in this book that I didn't actually think might happen. And right now, 3 years later, we've got a pretty good shot that we're going to hit 1.5 degrees centigrade in the next decade. The WHO gives it a 40% chance. And if you think the wildfires and the pollution and the droughts that's affecting the Midwest, and all of this is going to be getting worse, and this is at 1.1 to 1.2. This is serious. You need to learn about the climate. Please do not stick your head in the sand, and please get my book and share it. Because if I can get a voice in the climate dialogue, what I will do for Lyme, I will be able to talk about the effect of climate change in tick-borne. I will be able to talk about the effect of climate change in environmental toxins, because the mold is now getting into about 70 or 75% of my patients. You get a nice hurricane that gives you a waterlogged building, and your odds of getting mold toxicity are going to go all the way up. So I can use the dialogue for everything I know about Lyme and toxins and move it to the climate, that we can actually advance the Lyme agenda so people can learn about Lyme and tick-borne at the same point in time as giving them solutions. So personal protection, 20% on the skin is what I recommend most of the time for people. Permethrin-treated clothing is great. Nuke ketone should be coming out soon. You got to do frequent tick checks. And one thing that is really dangerous about Borrelia miyamotoi is the nymphs, which are the size of a pinhead. They've shown that in about 1%, like you could have maybe 500, 1,000 nymphs on you, you're not going to see them, and they will transmit Borrelia miyamotoi because it's transovarial. The mother will give the baby tick Borrelia miyamotoi disease without ever having to feed on an animal. So this is transovarial transmission. It's very effective, and they're now showing that these really tiny nymphs can transmit it. Not a lot, but it may get worse as time goes on. They're looking at prophylactic exposure. This is coming out of Mark Klempner's lab, looking at OspA human monoclonal antibodies. This is a really interesting approach where they're looking at human clinical trials that are pending, but they found that in non-human primates exposed to 20 infected ticks, they were 100% infected. And the monoclonal antibodies is kind of what you've heard about now with COVID. When you're getting monoclonal antibodies, it's the same idea. It's preventing it from happening. We have 50 bait boxes around our property. We have a little over 4 acres from New York Tick Control. Very effective with ultra tempo. We have not found a tick on our property in the last 10 years. And I wouldn't even walk on the sides of my property before because it was so tick infested. They're looking at bait vaccines for reservoirs like mice and chickmunks. Anti-tick vaccines to block transmission. This is the one that 𝗘𝗵𝗆 and I have been talking about forever, which is that's the vaccine that makes the most sense. This way, you're not going to get Babesia and Lyme and Bart and rickettsial infections in the same tick bite, because once the tick attaches, it's going to fall off, and they're working on that right now. They're looking at fungus to kill the ticks, 𝗙𝗏𝗏, transgenic ticks, 𝗏𝗃 vaccines, and the Valneva vaccine in Europe. They're saying it's quite effective at this point. They're not finding side effects because they took out the part that was immunogenic from the prior Lymerix vaccine. Again, I know the Lyme community is worried about it, but wait and see what they come up with. So in conclusion, COVID-19 and Lyme share similar symptoms because of the three I's: infection, immune dysfunction, and inflammation. Both Lyme and COVID are clinical diagnoses. There's a 30% false negative rate of antibody PCR for COVID. By the way, if you have a negative rapid test for COVID, that does not mean you don't have COVID. They made these tests for alpha. We're dealing now with Omicron with 57 different mutations. It is not picking it up. It's kind of like where we are in Lyme disease, where it's also not picking it up on antibody or PCR testing. Lyme and COVID both can cause acute and chronic symptomatology that overlap. So consider treating COVID with the nutraceuticals we talked about. We've had good luck with ivermectin. They did release Paxlovid, which is the Pfizer drug, which has an 89% efficacy. Personally, I didn't like the side effects when I read them in the PDR. I have not yet used it. I know that ivermectin has been safe and effective, but I'm sure someone out there is going to use it. I would consider treating Lyme for screening with the MSIDS map, because if you don't look at all the overlapping points on the MSIDS map, you're not going to figure out where all those sources of inflammation are coming from. And again, there is hope for the Lyme community with these persister medications and biofilm agents. This combination therapy, whether it's Dapsone combination therapy or Dapsone disulfiram or disulfiram alone, it's definitely helping a lot of resistant patients that we could not help even just 7 years ago. We've controlled the side effects of Dapsone, the anemia, methemoglobinemia. It's all in the published papers. So really, that's not an issue for people not doing it. But still, we're having a problem with Babesia Bart. And any of you who have connections with Lyme communities where you've got lots of funds, we need more funding for research on Babesia and Bartonella. Lyme, of course. But if I could have a cure for Babesia Bart, my success rate at this point would be 99.9%, because it's really the Babesia Bartonella is the problem I'm having with Dapsone or disulfiram therapy. So the next steps in research, I really believe, is going to be Babesia Bart. I'll tell you again about later on this year when we publish about this high-dose pulse Dapsone, very short courses. And again, please educate yourself on the climate. And March 1st, Starseed Revolution will be out. And anyone that doesn't think that it is funny and buys this book, you've heard me tonight, I will give you your money back if you don't find this to be one of the funniest books you have read in a long time while teaching you about the climate. And we got a very good book review from 𝗘𝗂𝗁, who could be actually quite severe with some authors. This fusion of eco-thriller, new age-powered speculative fiction, brutal social commentary, as you will see, and comedic science fiction a la Douglas Adams offers sedacious solutions to the present-day climate crisis, a strange little gem of a tale, or an allegorical how-to guide to save the planet. It is a guide to save the planet. That's why I wrote it. Only time will tell, an odd but thematically profound and engrossing sci-fi tale. We have videos, and I'm now on TikTok for the younger generation. I did 60 TikTok videos because apart from people now dancing on TikTok, which my wife decided, by the way, she would now like to do on TikTok, so I'm probably going to film her. She's going to do, I think, the Pleiadian, the Arcturian starseed dance. We haven't yet figured this one out. But for your kids or younger generation that are on TikTok, let them know about Starseed Revolution, Prince Ian on TikTok, because I do discuss a lot of the solutions and hope for the younger generation. And that's why I wrote this book, is to give people hope. Just like what I've been trying to do for the Lyme community is give you hope. There is hope for the climate. I promise you, I found the solutions. I just need people to institute them. That's the kind of sad part about it. So thank you for listening to me ramble on tonight, and let me answer all of your questions.
Dr. Horowitz, that was incredible as always. So thank you very much. Just chock full of information. So Amy Teal and I will tag team back and forth. We got a lot of questions, probably 40, 50 questions.
I'm here. Don't worry about it. Just throw them at me.
Well, that's right. Amy, do you want to start us off?
Sure. All right, let's get started. Say, first question, does the combination therapy work against TBRF, 𝗙𝗵𝗿𝗁 and/or brucella as well?
It depends what combination therapy you're talking about. So brucella, I mean, generally doxycycline and rifampin will work for brucella. Sometimes you do need other drugs like Bactrim or certain other drugs with it. The way you know if you've got an active brucella is by agglutination. Tick-borne relapsing fever, the truth is I don't think anybody knows. I've heard stories, I haven't seen it a lot, but I've heard stories of people that are Phage positive for 𝗿𝗂𝗵𝗵𝗿𝗃 through red labs, that are PCR positive. So I don't really know how well these persister drug regimens are working against the relapsing fever. That's like a big question. I would think it would work, but the truth is I have absolutely no idea.
Thank you.
An individual has asked about neurological Lyme and brain detox. Is there a detox protocol really specific for brain?
So most of the time, and I mentioned it during the talk, 2,000 milligrams of glutathione. It can be up to several times per day. You know, some people will do well with things like perarin. Perarin is a Chinese herb that helps with circulation. There's one I use from Orthomolecular called Membrin, which is huperazine, vinpocetine, and ginkgo, a little more brain circulation. But truthfully, glutathione with the charcoal bentonite clay that I was telling you earlier, GI detox, usually those kind of detoxes. And then, you know, some people need lymphatic drainage. They might do well with Bacana drainage at Thierry's. But most of the time, the load of the detoxification is usually done with charcoal, clay, and glutathione. But again, all the stuff I talked about, like saunas, flushing through the kidneys, keeping the bowels moving. I mean, you need to like work all the detox pathways if you're somebody who's having herxes and you're not getting better.
Okay. Is SOT therapy shown to be effective?
I personally have not had great results with SOT. I've had my worst, the one Dapsone patient, by the way, who was published in the study, who was BART fish positive, who got no response whatsoever. He tried the SOT for BART and for the others. He might have gotten slight help for the Epstein-Barr, but no help with the BART. Now, I've only had a handful of cases. I haven't seen anything published. I've asked, I know a lot of the Lyme docs out there are starting to look at it. I'm sure they're looking at it because obviously someone is having some success, although obviously it's quite expensive. Dapsone combination therapy, if you looked at it, it's a couple of $100 if it works. I don't know, you need to go to SOT therapy, but I think it's an interesting therapy, but I would like to see something published. I won't say it's unconscionable, but I find it difficult for people to pay because they're so desperate, thousands and thousands of dollars to do an SOT therapy that has not been published in the medical literature in a large case-controlled study. So, you know, word of mouth is one thing, and not that everything has to be published, but I would like to see some published studies.
I'm just going to follow that up. Can you just give a brief explanation of what that is? I'm guessing some people don't know what we're
SOT therapy?
Mm-hmm.
So it's a specific type of oligonucleotide sense therapy where they try kind of fooling your cells into how it recognizes and treats the bugs. And they basically take your blood, and I think they sent it to Greece or other places. I'm not sure. That's where I think where they've sent it. And they'll check you for different bugs like Bartonella, Epstein-Barr, Lyme, Babesia, and then they try and create these very specific nucleotide oligosens that go directly after the bugs that you have to tell your immune system how to fight and how to cure it. It's fascinating. I mean, I think there's got to be something to it because obviously there are some people getting help. But before you throw $1,000 at a therapy, you want to know, like, how well does it actually work and what my odds are? Just like people go to Germany and spend $15,000 on, you know, doing these hyperthermia options. And not that I don't think it makes sense. I talked about hypothermia 30 years ago that, you know, 𝗟𝗆𝗺𝗃𝗃 dies at, you know, 104 degrees in the body. So you can get the body temp for a couple of hours up there, open biofilms. It's possible that 1 4-day pulse of quadruple dose Dapsone with a hyperthermia treatment and you're done with your Lyme. I mean, that may be honestly where this goes in the future. I like hyperthermia. I like a lot of these alternatives, but there's not enough published research. The German doctors have not published their studies enough on this. So that's the only problem I have with it. I know it works for some people, but I've seen people come back from Germany and relapse months later. I don't think it does anything for BART. I think it probably helps some patients with Lyme that it lowers down their load. But, you know, frying your brain at 106, 107 degrees, I'd rather do 2 months of Dapsone therapy myself than have to put my brain at 107 degrees.
Using that theme of elevating the heat, far infrared sauna, you said that was one of the better detox to get in a sauna and get it, the bugs don't like the heat increase like that. Can you comment?
I love infrared saunas. I have an infrared in my basement. Infrared, I mean, truthfully, if you wanted to know, I mean, every person on the planet should be doing infrared saunas. Why? When you consider all in your body, the government has done nothing, zero, to be able to regulate these toxins. Like 1 out of 1,000 at this point has been looked at. They have not looked at how they interact in the human body. Red sauna and you're drinking enough, you're going to do a great job of getting these things out of your body. I mean, if it's mold, you may need to add some phosphatidylcholine along with it. But all of our mold patients, we recommend doing far infrared saunas, phosphatidylcholine, 3 grams twice a day with, let's say, 500 of glutathione twice a day with a GI detox. Very effective in removing the mold toxins. So yes, far infrared saunas is great. And a lot of the Lyme patients feel great. They go to Florida, they go to Arizona. Oh, doc, I feel great in the heat. Go get an infrared sauna. People feel much better in it.
Is there a connection between Lyme, Bartonella, and skin lymphoma?
Yes. So B-cell lymphomas have definitely been related. That's actually one of the few cancers that has shown up in the literature is B-cell lymphomas. And Bartonella definitely, I mean, Bartonella at this point has also been associated with melanomas. There's been cases of inflammatory breast cancer. The problem is that vascular endothelial growth factor, you might have tumors that are spreading in the body. So the fact is that it would not at all surprise me that Bartonella is underlying certain cancers, breast.
Bad connection.
I don't have enough, but the little bit of literature that has been published, yes, there is a relationship. I just don't think we know how far this has actually gone. That's an unknown.
Got it. I don't know if there's anything you can do on your end, but when you speak, you're freezing up. I don't know if it's a connection on your end, a wire, or I don't know.
I am wired in by Ethernet, and I have fiber optic cables at 3 times the normal speed in Ethernet. There is nothing I can do whatsoever.
It's certainly not on your end. So
it is all these people that are on at the same time. The internet was not made for this many people listening to talks.
It was, and it's only intermittent, so we are still picking it up.
All right. Going another direction. How do you treat patients who are allergic to drugs containing sulfonamide? Did I say that right? Like Dapsone.
Well, so first of all, the patients that are allergic to Bactrim, like let's say you had a urinary tract infection, you got a rash, only 1 out of 100 people who are allergic to Bactrim have a problem with Dapsone. Dapsone is not as allergic. And if someone says I have a Bactrim allergy, what we usually do is we put them on an H1/H2 blocker like 𝗬𝗕 and pepsid, famotidine. So we're blocking histamine 1 and histamine 2 receptors. And then we just give them a test dose of Dapsone, like a 25 milligram one time. And honestly, I don't see rashes with Dapsone. Disulfiram, it's about 3 out of 100. Disulfiram is also a sulfur drug. Still not as bad as Bactrim, but we found that the rashes are probably a little bit more with disulfiram than Dapsone. There's ways, by the way, to get desensitized, but fortunately, the only one you would not give Dapsone to is if someone said, and I've never seen a patient with it, I have Stevens-Johnson syndrome, which is an autoimmune disorder from taking drugs like sulfonamides that literally the skin peels off. You would not give a sulfur drug in any way, shape, or form to someone like that. But I've never seen a patient like that. And I have given Dapsone to people that are sulfur allergic, and they're great. They're fine. But we give them an H1/H2 blocker.
Great, thank you.
But again, we're not talking people that their throat closes with anaphylaxis, right? We're talking mild rashes. Right? If you're someone who has a severe allergic reaction, that you need to do that in an allergist office and get this checked out.
All right.
Can you comment on individuals that are non-methylators that might have a MTHFR genetic predisposition?
I personally, after all these years of checking NTHFR status, I don't really find, honestly, it's that big a deal. I know some people think methylation is, huge. It's not in my practice. I mean, now, that being said, I am methylating the hell out of people, because some people, by the way, are over methylators. People that are over methylators, if they were to try my protocol, they would like probably be feeling that they're standing on pins or something, because they're like getting ready to jump out of their skin. They're so anxious. But I don't have over methylators even in my practice. So, we'll find people that are heterozygous, rarely homozygous. The ones who's got high homocysteine, they need B6, B12, and folic acid. The ones whose kidney functions are elevated, they need more. But honestly, I'm giving massive amounts of methylation support to people, whether it's methylprotect from Zymogen, whether it's MTHFES, whether it's folic acid. Folify ER is 5-methylfolate, like 15 milligrams of methylfolate we're using for Dapsone. I don't see a problem in my practice. So we are methylating. Methylation is one of your 6 detox pathways in your phase 2 for your liver. So methylation is one, glutathione is one, right? There's a bunch of them. We're kind of supporting the methylation pathways. But if you are an over-methylator, that can be a problem. And then you need to kind of work around it a little bit by finding ways to work the biochemistry. But it hasn't really been an issue for us.
What's your opinion in terms of sexual transmission of Lyme disease?
Is it possible? Yes. I mean, the studies that have been shown by Stricker and Mprin-Middelveen, yes, it's possible. But the reason I don't think it happens frequently, when they looked at the number of spirochetes in the sperm and in the vaginal secretions, they were very small. Normally, to transmit an infection, like if you need to get, let's say you want to get strep, you need to have lots of strep in your tonsils to be able to transmit that. It's not 1 or 2 streptococcus. If you've got 1 or 2 spirochetes, it's possible, but usually it's the spirochetal load that's going to determine whether your immune system can handle it. Now, let's say you had herpes viruses and you happen to have a genital lesion. Certainly possible. A spirochete can get in there. I know people that have sworn to me it was sexually transmitted. I don't doubt them. It's possible. But we don't have enough at this point. The animal models, Ray Stricker has been talking about doing the actual animal transmission model. It hasn't happened yet. I mean, it really needs to happen to kind of answer the question, but is it possible? Sure. I think it's definitely possible.
Gotcha. Sorry, Amy, I'm going to jump on one more. There was a question on, you had commented on melatonin in its relationship to sleep, but you had another comment about that. You then followed up that there was an herb, maybe started with the letter H, that you suggested for sleep. Can you comment on both of those?
Yeah, so when I was talking about melatonin, I was talking about it from the point of view of these 3 switches, these inflammatory switches, the last one being NLRP3 inflammasomes, which melatonin shuts down. So there are different types of herbs. And in fact, I think I have them in the back of my book for people that want to look this up. But honokiol, Honokiol, I think is the one you're probably talking about.
I think you're right.
Honokiol is one of these herbs that I find works generally well with Lyme, that when you mix it with orthobiotics, Serenity PM, Synovix Calm is the valerian root by Zymogen. There's all of these different herbal products out there, even the 𝗘𝗵𝗴𝗁𝗃. I have great results with 𝗘𝗵𝗴𝗁𝗃. Ortho just made a 𝗂𝗶𝗏, which is 𝗘𝗵𝗴𝗁𝗃 in a dropper. If you stimulate GABA receptors in the brain, that's how you shut off your brain. So, if you combine these things, I find that they generally work when you use it with or without medications.
All right, another question here. My son cannot tolerate glutathione or NAC even at tiny doses and even after weeks of tiny dosing. What would be causes and how can he tolerate?
The product that he may want to eventually try is called Continual G. Continual G is glycine, is a precursor of glutathione. It is not NAC and is not glutathione. People that have had problems tolerating glutathione usually can tolerate Continual G, and they have done scientific studies showing that it will increase the cellular and intracellular glutathione levels. We've used it in Lyme patients, and some of my patients have definitely liked it a lot. You make glutathione with, glycine, glutamic acid. There's like amino acids. So usually I don't do a lot of like whey-based protein drinks, but whey-based proteins contain cysteine. So, maybe somebody that can't take cysteine, maybe they can tolerate a whey protein drink if they're not sensitive to dairy. But otherwise, the Continual G is something they may want to look at.
Question was asked, you had mentioned about your questionnaire. Is that something you can post, or is that something that you have to be a patient?
Oh, it's posted on my website. If you go on cangetbetter.com, and you go under that site, you will see that the questionnaire is there. You can just go on and use it. It's for everybody to use. Just like the COVID protocols. It's on my website. It's for any doctor, any patient to use. You know, when I find something that works, I just post it so people can use it.
That's helpful. At one time and recently, I was under the impression you were not taking new patients, but only in the last couple of days, somebody was floating around an email that maybe you are taking new patients.
We are starting to open up our practice. So what's happened, in fact, I posted it early. It's funny you say that because I posted it earlier today. Yes, we are starting to open up our practice now that a certain number of our patients have gotten better from these persistent biofilm protocols. Now that they're better, I have room for other patients.
Excellent.
So yes, we are starting to open up to other patients, and appointments with an S, appointments at 𝗘𝗃𝗁𝗃, it stands for Hudson Valley Healing Arts Center, appointments with an S at 𝗙𝗵𝗴HAC.com. That's how you contact the office if you're interested.
Okay, to ask a question, Eric?
Sure.
What have you found to be effective for persistent mycoplasma pneumonia?
So the kind of combo protocols, first of all, mycoplasma titers will stay positive and elevated for years in people. So you need to understand, just because you have high positive mycoplasma titers, you don't actually know if a bug is active unless you have a 4-fold increase in antibody titers. So just like Epstein-Barr can have high titers for years, it doesn't mean you're active. Same thing with mycoplasma pneumonia. The only way you know if mycoplasma pneumonia is active is PCR. Now, I have found mycoplasma species that some of them were persistent with the older protocols we used. The key to mycoplasma, which is the same for chlamydia, the same for Lyme, the same for rickettsia, the same for anaplasma, the same for Ehrlichia, for Brucella, they're all intracellular. So one drug alone is not enough for mycoplasma. I did that study 25 years ago and presented it, I think, at like the 13th International Lyme Conference when Karen Forshner was doing like her LDF. We did studies where we found mycoplasma PCR positive with people who did doxy alone, 𝗧𝗕𝗗𝗃𝗁 alone, quinolone, drugs that normally go after mycoplasma. The key with these intracellular bugs is combination therapy. So that's why usually we find that 𝗙𝗂𝗄 is a very common and well-tolerated protocol for most. You just got to be careful with drug interactions with rifampin, because if you're on birth control, you're on thyroid hormones, you're on other drugs, the rifampin can affect it. We get around that by sometimes pulsing the rifampin. So instead of then rifampin every day affecting your drug levels, you could do like 2 rifampin twice a day, 1 day a week, or 2 days a week, so you're not affecting the drug level so much of the others. But these combo regimens of a tetracycline with rifampin, without a macrolide, without pyrazinamide, it'll go after mycoplasma.
Okay.
You had brought up a mitochondrial regeneration process that you touched on. Could you expand on that, please?
This should be in the back part of How Can I Get Better? I think I have it back there, but the process that we use is ATP 360 from research. Place the good fatty acids in the mitochondrial membranes, which is what the ATP 360 does. We then use 𝗂𝗄-Power. It's a 400 milligram CoQ10 twice a day, because you need the CoQ10 for the mitochondrial transport chain. We use NADH. Inada is one of the brand names, 5 milligrams once a day. And then the last one is acetyl L-carnitine. The brand I use is Zymogen, their Carnitex. But you can get it from many different brands. And as it sounds like carne, meat, like if you're normally a meat eater, you're probably not going to need too much L-carnitine. You're going to get it from your diet. But the vegetarians may need a little extra help. And some people, by the way, do like D-ribose and they do other things, but that combo is usually the one that seems to make the biggest difference.
Do you think the Cowden protocol is effective for Babesia and Bartonella?
Which protocol?
Cowden?
Well, they're helpful, but they're not curative. I mean, none of the herbal protocols are curative. They will help with the herbs. I mean, the initial Cowden protocol, I did the studies on it when Nutramedics sent me samples probably 20 years ago. And 𝗍𝗂𝗄𝗏 looked in the lab and found that cemento-bandrol were lowering the loads of spirochetes. It's not that these things don't work and lower the loads and help. They do. but they're just not going to completely eliminate them from your body. And that's why these persister drugs are necessary. But, if you use biofilm agents with some of these drug regimens, whether it's traditional Chinese herbs, 𝗙𝗂𝘁, 𝗟𝗵𝗴𝗁-HH, using Susan McCamish's Beyond Balance, using the 𝗟𝗆𝗺𝗃 from Byron White, using the Cowden protocol, they're all helpful, right? I mean, I'd probably say on the average, I get at least a 70% response rate, but they just don't hold people. They're just not enough to knock it out. My goal is to cure people or get at least as close to a cure that I don't have to leave you on herbs or antibiotics for the rest of your life.
That's certainly a good thing to be working towards. Amy, I'm gonna grab one question here. If you see one question that's good for you to close it out, let's go ahead and wrap this up at 9 o'clock. I've got about 3-4 minutes before 9. So do you see a question that you want to highlight? I actually see two. Let me go with mine. And then if you have one, go right ahead. Because one, whoever asked this, I'm really surprised to see it written out because I completely suffer from it, but I've never heard anyone else does. But before I get to that one, Candida, can you comment on it about the prevalence of that with Lyme patients? The comment is the individual is seeing a Lyme literate medical doctor as well as a general practitioner who don't seem to really want to embrace that in terms of understanding it or correcting it. So can you tie that together for us?
Yeah, so when you go to med school, nobody really teaches you about Candida except like, oh, you get a fungus in your mouth or a vaginal yeast. They don't really teach you about Candida syndrome, right? So the thing about it, it is a real syndrome. There's no doubt about it. You do a CDSA, a comprehensive digestive stool analysis, you can see some people with 3+, 4+ yeast in their colon. And the problem with the yeast is that if you've got pathogenic yeast in your colon, there are two different types of yeast. One is the spore form, and the other is the hyphae, which are like the roots that go into your intestinal cell walls. So what happens is when people get Candida is they can get an inflammatory response that can lead to leaky gut from the inflammation. That leads to spreading food allergies where you start getting more and more food allergens over time that you're reactive to. And the whole thing just starts to cycle after a while. So the way you generally know if you have Candida is most of the people with Candida also suffer from reactive hypoglycemia. They find it 10 a.m. in the morning or 4 o'clock in the afternoon, they hit a wall, they all of a sudden start yawning, they feel very tired, they feel like they're gonna pass out, they get dizzy, they get palpitations. Those people that hit walls, and it could be adrenal also, adrenal causing hypoglycemia or adrenal with hypoglycemia, they're related. But those people that have reactive hypoglycemia is usually part and parcel of the Candida. So for example, I have Candida and hypoglycemia. If I'm good with my diet and I don't eat too many carbs in my diet, I don't get any bloating, I don't get any problems, I feel absolutely fine. Over the holidays, when I went a little wild with my diet, I know when my diet is off and my bowels are not happy with me because there's a certain odor. I don't want to go into too much detail with it about the Candida, but let's just say that my body makes it very clear when there's a dysbiosis happening in my gut. And once I take like 1 or 2 days of diflucan and knock it out and stay at a low, it's completely gone. But the Candida patients, the problem with it is that if you don't do something to knock out the Candida, and by the way, it's not easy to completely get rid of. Candida is under biofilms, just like Lyme and Bartonella, of what we've been talking about. So is Salmonella, so a lot of these. Getting rid of Candida 100% is not easy at all. But I'd say for most people, I'd say at least 10% of my practice has it. We give them nystatin every time they're on an antibiotic. I don't care what it is. They're all on nystatin. They're all taking essential oils, which are not only biofilm agents, but lower Candida. They're on 3 different probiotics with Theralac, orthobiotic, and Saccharomyces, which is a healthy yeast, which crowds out Candida. And Saccharomyces is also good for mold. So, the thing is that the problem is that fatigue, brain fog, muscle pain, joint pain, anxiety, sleeplessness, there's symptoms of hypoglycemia, there's symptoms of Candida, there's symptoms of Lyme, there's symptoms of BART. So the problem is the symptoms all overlap. But if you put sugar in your diet and all of a sudden you feel tired and you get bloated and sometimes your tongue gets white or women will get, vaginal discharge, then you've got a Candida problem that's there, especially if you check the microbiome on a CDSA And some people feel tremendously better clearing out for yeast. Like, oh, I thought it was my chronic Lyme. I thought my fatigue and my fog and stuff. And it's like, nope, it was Candida. The Dapsone actually knocked it out. It was Candida. But you won't know until you actually test it. And I read Crook's book. What a horrible name for a doctor. Dr. Crook? Really? Couldn't you have like changed your name or something? So I read his book years ago on Candida, which is how I learned about it. But it is an absolute clear syndrome. There's not even one doubt that it is real. It is not made up in people's minds. So when some doctors, usually the functional medicine doctors get it, but you know, some doctors get it more than others. That's all I can tell you.
So another question, this is one of the ones that I was interested in as well. Is Bartonella or mold the bigger issue?
In my practice, it's BART. BART is the number one issue, number one, followed by Babesia, followed by mold. If you ask Neil Nathan, he'll tell you mold is number one. Lyme, you know, every Lyme doctor's practice is going to be different. But there's not a doubt in my practice, it is BART. You know, Babesia is annoying and it makes people feel bad, but it doesn't make them feel as bad as Bartonella. Like, I can mix around Mepron, Malarone, Zithromax, Bactrim, Cryptolepis, Artemisia, Coarctum, Lumefanthine. I mean, I can rotate all these things in, and even if I can't cure it, I can knock down the load enough that you will tell me your Babesia symptoms are better. The problem with BART is that even after you've sometimes given them longer courses of disulfiram or Dapsone, you'll get a positive BART fish that'll come back and the symptoms will start relapsing. It is a very, very difficult bug to get rid of. It is by far, for me, 100 times more difficult to get rid of Bartonella than Lyme. And when I say get rid of, I mean like the 99% of Dapsone or disulfiram, like there might be a straggler that's hanging on, like, oh, I took my COVID booster or something, kicked up, and then it went away and I'm still fine. My wife now is fine again. She was asymptomatic for 3 years after double dose Dapsone. She got, you know, her Pfizer vaccine. After the second one, she got a little bit of some neck stuff, which was kind of reminiscent. It went away over time without my treating her. So her immune system was strong enough, but every one of her MSIDs, you know, her POTS is now better from doing autonomic exercises. Her adrenals are being treated. She's sleeping properly. Her mast cell disorder has to be treated. She takes Zyrtec, she takes you know, it's like, but I had to treat all these MSIDs factors to get my wife better. It wasn't just the Lyme, but it was the Dapsone protocol that made sure that I never had to give her another treatment in the last 3.5 years. She still needs treatment for POTS, but she's coming off the midodrine as she's doing the autonomic nervous system exercises. So, you know, the talk tonight was highlighting, you got to go after the MSIDS model, right? You can't ignore POTS. You can't ignore, oh, I never had my adrenals done. The adrenals could be the reason why you're not getting better. So each one of those can be like a nail in your foot that if it's not pulled, you're just not going to get the full clinical response that you would expect to see.
Very helpful. Thank you. The couple of people in the chat, as well as in the questions, wanted to know to spell out the email address. If you're looking at me on screen, you'll see my name. I changed it to appointments@𝗏𝗏hac.com. That's appointments for
That's it.
Dr. Horowitz. So the last question is the relationship between flying and high altitude and herxing. There was a stretch there for a year. I would fly maybe 5 times every other month. I would herx tremendously.